Welcome to the funnel effect. Today, we're diving deep, really deep, into one of the trickiest areas in heart procedures, dealing with coronary bifurcation lesions. These are the spots where an artery splits, and treating them, well, it's complex.
It really is critical territory. And our guide today is a fantastic expert review. It's titled Drug-Coated Balloons for Coronary Bifurcation Lesions, published in Eurointervention just this year, 2025. We're drawing heavily on the insights from the main authors, Simona Fezzi, Bruno Scheller, Tuomas T. Rissanen, and their colleagues.
Right, and we're not just scratching the surface here. Our goal for you listening is to really get a practical, solid understanding of how drug-coated balloons, or DCBs, are changing the game for these bifurcations. We want to go beyond just the idea of leaving nothing behind and dig into the how and why it works.
Exactly. The mission here is a full understanding. How does this leave nothing behind idea actually play out in the cath lab? We'll cover the techniques, the best ways to sequence the steps, and look hard at the clinical proof that backs up this shift towards DCBs, especially, for patients who might be at higher risk.
Okay, so let's start by setting the scene. How common are these coronary bifurcation lesions, these CBLs?
They're definitely not rare. You see them in roughly 20% of all PCIs, that's percutaneous coronary interventions. And the problem is, procedures involving bifurcations tend to be less successful right off the bat. And critically, the long-term outcomes for patients often aren't as good compared to simpler non-bifurcation blockages. The anatomy itself is just inherently challenging.
And for years, the go-to solution has been the drug-eluting stent, the DES. They were revolutionary, no doubt, but putting permanent metal scaffolding at such a complex junction, it sounds like it causes issues down the line. What are the main drawbacks the review points out with DES here?
Well, you can think of the drawbacks in two buckets, really, mechanical and pharmacological. Mechanically, you've got this permanent metal cage. It carries long-term risks like instant restenosis or ISR, that's the blockage coming back inside the stent. There's also stent thrombosis, which is a clot forming on the stent, and something called neotherosclerosis, basically, new plaque building up inside. The review mentions these things happen at a rate of about 2% to 3% per stent per year. It adds up.
Okay, so ongoing risks from the metal itself and the pharmacological side, that's about managing the patient, right, with blood thinners.
Precisely. The permanent metal means patients need long-term dual antiplatelet therapy, DAPT. And that's a big issue, particularly for patients at high bleeding risk, or HBR. Think elderly patients or those already on anticoagulants for other reasons. Prolonged DAPT significantly increases their risk of serious bleeding. Plus, from a procedural standpoint, DES can jail the side branch, the SB. The metal struts can block access or flow into that side vessel.
Right, which is where DCBs come in as this really attractive alternative, delivering the drug but without leaving that permanent scaffold behind. What makes them theoretically better for tackling restenosis in a tricky spot like a bifurcation?
So DCBs deliver the same kind of anti-proliferative drugs that are on the stents, but crucially, without the permanent implant. The advantages are pretty clear, theoretically. You get targeted drug delivery right to the opening of the side branch, the SB ostium, without putting a cage over it. You avoid the potentially inflammatory polymers, often found on stents, and you ditch the permanent metal that can trigger late thrombosis, or that neotherosclerosis we talked about.
And you preserve the natural artery structure. That must have functional benefits too.
Absolutely. Keeping the native artery geometry means you maintain what's called physiological vasomotion. That's the vessel's natural ability to expand and contract as blood flow changes. It's important. And going back to those high bleeding risk patients, this is huge. No permanent implant means you can potentially shorten or de-escalate that DAPT much earlier, a major safety win for them.
Can you say a bit more about the drug delivery itself? It's not just a quick wash, is it?
No, definitely not. These balloons are designed for a rapid release of a really high concentration of the drug right onto the vessel wall. And that high concentration sticks around for weeks, long enough to shut down the cell multiplication process that causes the blockage to come back, the restenosis.
The review mentions two main types of drugs used on these balloons, paclitaxel versus sirolimus. How do they differ?
Yeah, they tackle that cell growth problem in different ways. Paclitaxel, or PTX, is the older, more established one in DCBs. It's very lipophilic, meaning it gets absorbed easily into the fatty cell membranes of the vessel wall. Its mechanism is kind of structural. It messes with the cell's internal scaffolding, the microtubules, stopping cells from dividing.
And the newer ones, the Delimus drugs, like sirolimus, often found on DES too.
Right. Sirolimus works differently. It inhibits a key pathway called mTOR. Essentially, it stops cell proliferation earlier in the cycle, specifically blocking the jump from the G1 to the S phase.
And clinically, has one type proven better than the other in head-to-head comparisons?
The data is a little nuanced there. A meta-analysis actually found that paclitaxel-coated balloons, the PCBs, showed better results angiographically, meaning when they measured the vessel dimensions later, the PCBs resulted in less late lumen loss, or LLL. The LLL was about -0.11 millimeter better, suggesting better immediate anti-restenotic effect. But, and this is interesting, the overall clinical outcomes, measured by things like target lesion failure, TLF, were actually similar between the two drug types.
Huh. So better vessel measurements didn't necessarily translate into fewer major problems like repeat procedures or heart attacks. Why might that be?
That's a really key question the authors touch upon. It suggests that while PCBs might leave the artery looking wider on an angiogram right after maybe a few months later, that difference might not be significant enough clinically to prevent major events down the road, the things that make up TLF, like needing another procedure or, worse, cardiac death. It could be due to differences in the patients studied, or maybe there's a slight late catch-up effect where the initial angiographic benefit of PCB fades a bit over the very long term. It really highlights why we can't just rely on how the vessel looks on an X-ray. Clinical endpoints, how the patient actually does, are what truly matter.
Okay, so the potential benefits of DCBs are clear, but the review really hammers home that success totally depends on doing the procedure perfectly. Let's shift to technique. They say vessel preparation before the BCB is absolutely critical. Why is that step so foundational?
You've hit the nail on the head. Preparation is everything. If you don't prepare the lesion properly, the DCB is likely to fail. Think about it. The drug needs to get into the vessel wall to work. If the wall is covered in hard, calcified plaque that hasn't been cracked or modified, the drug will just sit on the surface, maybe get washed away by blood flow, and you won't get that sustained effect. It needs a receptive surface.
So what does good preparation involve for the operator in the cath lab?
It typically starts with predilatation. You use semi-compliant or more often non-compliant balloons and C balloons. You want to match the balloon size pretty closely to the artery size, like a 1.1 ratio, to really open up the blockage effectively. But if that standard approach doesn't work well, say the lesion springs back what we call recoil, or it just doesn't expand properly, you have to escalate your strategy right away.
And escalation means bringing out the more specialized gear.
It's exactly. For tougher, more fibrous lesions, or those with moderate calcium, you might go to high-pressure NC balloons. Or you could use cutting or scoring balloons. These have tiny blades or wires designed to make controlled breaks in the plaque, making it easier to expand. And for the really tough, heavily calcified lesions, the sources are clear. You need aggressive calcium modification. That means things like rotational atherectomy, basically drilling out the calcium, or intravascular lithotripsy, IVL, which uses sonic waves to crack it.
The review gives a great example using imaging, particularly for a left main bifurcation, right?
Yes, a really illustrative case. It was a complex left main CBL, a Medina 1111, meaning disease in all three parts. The main vessel before the split, the main vessel after the split, and the side branch. They used optical coherence tomography, OCT, which gives incredibly detailed pictures from inside the artery. And the OCT confirmed that aggressive prep, in this case using orbital atherectomy, another calcium-removing tool, was absolutely necessary. It showed they got deep calcium fractures, creating pathways for the drug. It just underscores how vital imaging is to confirm you've done enough prep, especially in such a critical location like the left main.
Okay, prep is done, vessel is ready. Now for the main event, sizing and inflating the DCB itself. Are the rules different from using a regular balloon?
Yes, there are strict rules focused on maximizing drug transfer while minimizing vessel injury. Sizing needs to be precise. Aim for a DCB to vessel ratio of about 0.8 to 1.1. You don't want to oversize aggressively. But the absolutely crucial part is the inflation time. You must keep the balloon inflated for at least 30 seconds, and often the recommendation is 60 seconds or even longer, depending on the device.
That sustained inflation time sounds non-negotiable.
It is. That's how the drug gets delivered. The drug is usually mixed with a carrier substance on the balloon surface. That prolonged, steady inflation gives the carrier time to dissolve and the drug enough time to transfer effectively into the vessel wall tissue. And then importantly, you do this at relatively low pressures, typically 6 to 10 atmospheres, to minimize the risk of causing dissections or other damage.
After you've done the DCB inflation, how do you know if it's worked? What counts as procedural success?
Angiographically, meaning how it looks on the X-ray, success is usually defined as having a low residual blockage, or stenosis. Visually, less than 30% narrowing is good. If you measure it quantitatively, less than 40%. And importantly, small tears or dissections in the vessel wall are often acceptable as long as they aren't limiting blood flow. We want good TMI3 flow and don't look like they need a bailout stent.
Now let's talk about a big warning sign the review puts up: avoiding kissing DCB inflation, or KBI. Kissing balloons is a standard technique in bifurcation stenting. Why is it such a no-go with drug-coated balloons?
Yes, avoiding KBI with two DCBs simultaneously is a fundamental rule. The authors give three main reasons why it's a bad idea here. First, and most importantly, inflating two balloons side by side significantly increases the risk of tearing or even perforating the main vessel just proximal to the bifurcation. Remember, in a DCB strategy, that proximal main vessel doesn't have a stent protecting it, so any injury there is potentially very dangerous.
Makes sense. What are the other two reasons?
Second, the KBI maneuver itself, often involving multiple adjustments and inflations, means the DCBs are exposed to blood flow for longer than necessary. This leads to the drug washing off the balloon before it can get into the vessel wall. You lose your therapeutic effect. And third, the way the two balloons push against each other and the carina, the divider between the branches, means you don't get smooth concentric drug application. The drug delivery becomes patchy and suboptimal, especially right at the crucial point of the bifurcation. It's just not an effective way to deliver the drug, even though it's useful mechanically for opening up stents.
Okay, we've got the how-to down. Now let's look at the different ways DCBs are actually used in practice for these bifurcations. Starting with let's say, the ideal vision, the leave nothing behind or DCB-only strategy.
Right, this is the ultimate goal for many proponents. It's very appealing because you completely avoid any permanent metal implant. This maintains the vessel's natural geometry and eliminates problems like carina shift, where a stent might push the divider over and compromise the other branch.
And where does the current evidence suggest this DCB-only approach is actually feasible and safe right now?
Primarily, it's supported for lesions confined just to the side branch ostium, the opening. This is what's called the Medina 0001 classification, where the main vessel is essentially healthy. We even have physiological data supporting it. The review mentions cases where, after treating the SB with just a DCB, they measured the blood flow using IFR instantaneous wave-free ratio. Getting a good value, like 0.94 in the example, confirms you've achieved a good result, relieving the ischemia without needing a stent.
What about clinical outcomes? Are there studies showing this works long-term?
The studies are encouraging, though often relatively small so far. Schultz and colleagues looked at 39 patients, even including some left main cases treated with DCB only. They found really low rates of restenosis in the SB at 4 months, only 3.3%, and low overall MAE rates, major adverse cardiac events, at 7.7%. Maybe even more striking, a study by Kinney et al. Directly compared DCB only to putting in two stents. They found that the DCB only group actually had better late lumen loss results, meaning less re-narrowing in both the main vessel and the side branch at 12 months. That suggests positive remodeling.
Wow, being superior to a two-stent strategy is pretty compelling. So what's holding back DCB only from being used everywhere? What are the limitations?
The main thing is the lack of really large, robust clinical trial evidence, especially for treating de novo lesions, new blockages in the main vessel itself, particularly in larger arteries and, critically, in the left main artery. The small studies are promising, yes, but we need more large-scale validation before it becomes the standard for complex, widespread disease beyond just small side branches.
Got it. So for many complex cases, the more common approach right now involves mixing things up, the blended or hybrid approach. This usually means putting a drug-eluting stent, a DES, in the main vessel for support, and then using the DCB for the side branch.
Exactly. This blended strategy fits really well with the provisional stenting philosophy, which is the standard way to approach most bifurcations. It follows the European Bifurcation Club's KISS principle: keep it simple and safe. The idea is you secure the main larger vessel with a reliable DES, but you use the DCB for the side branch to minimize the total amount of metal left behind in that complex bifurcation zone.
Now, before we get into the sequence, you mentioned a critical step called POT, proximal optimization technique, being mandatory in this hybrid approach. Can you quickly explain what POT is and why it's so vital?
Yes, POT is absolutely fundamental here. It involves taking a short, non-compliant balloon and inflating it at high pressure only in the most proximal part of the main vessel stent, the part before the side branch takes off. It does two crucial things. First, it makes sure the stent is pushed firmly against the vessel wall in that proximal segment, which is often wider than the segment further down. Second, and very importantly, it flares the stent struts open right opposite the side branch opening. This makes it much easier and safer to get wires and balloons back into the side branch if you need to. Without POT, the stent might not be well opposed proximally, and access to the side branch can be compromised.
Okay, POT is essential. Now, with that in mind, how does the timing of the DCB treatment change the hybrid strategy? Let's start with doing the DCB in the side branch before putting the main vessel stent in.
All right, so the sequence goes like this. First, thorough lesion preparation in both the main vessel and the side branch. Then you inflate the DCB in the side branch. After that, you deploy the provisional DES in the main vessel, positioning it across the side branch opening. And finally, you perform the mandatory POT on that proximal part of the main vessel stent. This way, the SB gets its drug treatment before it's potentially jailed by the stent.
But you mentioned a potential downside, mechanical issue with this timing.
Yes. The main worry here is that the subsequent maneuvers, especially the high-pressure POT inflation in the main vessel stent, could potentially squeeze or mechanically disrupt the drug that you just carefully delivered to the side branch wall. There's a concern it might compromise the DCB's long-term effect.
Okay, so that's one way. What about the other main sequence? Treating the side branch with the DCB after the main vessel stent is already in place, sometimes seen as a bailout or planned second step.
This sequence often feels more like the standard provisional workflow for many operators. You place the DES in the main vessel first, then you perform that mandatory POT. If the side branch looks pinched or compromised, you then carefully guide a wire through the stent struts into the side branch, maybe dilate it with a small balloon. Then you apply the DCB to the side branch through the struts. The procedure usually finishes with another mandatory POT, a re-POT, to make sure the main vessel stent is perfectly shaped after the side branch work.
This way sounds like it protects the main vessel stent integrity, but does it potentially hurt the DCB's effectiveness in the side branch?
That is the core debate. The potential issue here is getting suboptimal drug delivery. Those stent struts are now acting as a physical barrier between the DCB and the side branch wall, potentially hindering drug transfer. Also, if that side branch needs more aggressive preparation after being jailed, say, with a cutting balloon, just getting the device through the struts can be challenging, let alone ensuring adequate prep before the DCB goes in.
So it's a bit of a trade-off. Strategy 1, DCB first, risks disturbing the drug during POT, while strategy 2, DCB after stent, risks poor delivery through the struts. Which way are people leaning based on the review?
The review acknowledges both strategies, and the provisional approach often leads to strategy 2 happening reactively. However, they also highlight the theoretical drug delivery concerns with strategy 2. Many experienced operators who plan to use a DCB in the side branch might actually favor strategy 1. The rationale is that it guarantees the drug gets to an unprepared, ungaled vessel wall first. Then you just have to be very meticulous with the subsequent POT to minimize carina interaction. The key takeaway is that neither is perfect. Both require real precision, and ongoing research is trying to nail down the absolute best timing for maximum drug efficacy.
Theory and technique are one thing, but let's get into the clinical proof. Where does the evidence really stand for DCBs? Let's start with the most basic comparison. Using a DCB versus just a plain old balloon angioplasty, or POBA, for the side branch.
Right, this is the foundational evidence. And here the data is pretty clear. Multiple large meta-analyses have looked at this, specifically within the provisional stenting strategy, SB treatment. They consistently show that DCBs are superior to just using a regular balloon for the side branch. You see less late lumen loss, smaller residual stenosis, and significantly lower rates of binary restenosis, the blockage coming back in a significant way.
And did that translate into better actual outcomes for patients, like fewer major adverse cardiac events, or ME?
Yes, absolutely. The ME rates were consistently and significantly lower in the groups treated with DCBs compared to POB, looking out to 9 and 12 months. One analysis, for instance, reported an odds ratio of 0.45 at 12 months, strongly favoring the DCB. And remember, ME typically includes serious events like cardiovascular death, heart attack MI, and needing another procedure on the same spot, TLR.
The review points to the DCB-VIF trial as being particularly important here. What did that specific large trial show?
DCB-VIF was really a landmark trial. It was the largest randomized controlled trial, RCT, focusing specifically on true bifurcation lesions, with nearly 800 patients enrolled. It provided what we call level 1 evidence, the strongest kind, showing that treating the side branch with a DCB was statistically superior to using a standard non-compliant balloon, POBA. The reduction in MANC at 12 months was quite striking. It was 7.2% in the DCB group versus 12.5% in the POBA. That translates to a hazard ratio of 0.56, meaning a significantly lower risk with DCB.
That's a big difference, over 5% absolute reduction in major events. What drove that benefit? Was it just fewer repeat procedures in the DCB group?
That's where it gets interesting. The main driver for the lower MBCE rate was actually a significant reduction in myocardial infarction heart attacks. Surprisingly, the rates of needing a repeat procedure, target lesion revascularization or TLR, were actually pretty similar between the DCB and POB groups. When they looked closer, it seemed the higher MI rate in the POB group was mostly due to events happening early, around the time of the procedure itself, periprocedural MIs, which didn't necessarily lead to needing another intervention later on.
So the DCB, maybe through its drug effect, seems to provide more stability to the side branch immediately after treatment, preventing those early injury-related MIs better than just mechanical stretching with POB.
That appears to be the most compelling explanation. The anti-proliferative drug, even in that acute phase, seems to stabilize the plaque in the vessel wall more effectively and safely than simple balloon dilation alone. It reduces those high-risk acute complications.
Okay, now let's move to the really complex end, the left main artery. You mentioned the hybrid DES plus DCB approach is particularly intriguing there. Why the special focus on the left main?
Well, the left main is often called the widowmaker for a reason. It supplies blood to the majority of the heart muscle. So getting the treatment right there is absolutely critical. The blended DES plus DCB approach is appealing because it gives you the reliable scaffolding of a DES in the main trunk, but minimizes the amount of metal near the origin of the two crucial downstream arteries, the LAD and the circumflex. There was a large study by Pan and colleagues using propensity matching to compare similar patients, nearly 600 of them. They found this hybrid DES plus DCB strategy was linked to significantly lower rates of clinically driven TLR needing another procedure compared to using DES-only strategies. It was about 2.9% versus 9.4%. Target lesion failure was also lower at 2 years.
And did the vessel itself look better on follow-up imaging in the left main with this hybrid approach?
Yes. Another study by Lewitt et al. Specifically compared DES plus DCB against using 2 stents in the left main. They found the hybrid group ended up with a wider minimal lumen diameter and less late lumen loss, specifically in the ostium, the opening of the left circumflex artery. This supports the idea that avoiding a second stent helps maintain better long-term patency in that critical side branch area.
Despite all this positive data, the review does caution us about the quality of some of the older studies and the need for standardization now. What's the main weakness in the current trial landscape?
I'd say the biggest issue is heterogeneity. Many of the existing randomized trials comparing different strategies have relatively small numbers of patients. Plus, there's often significant variation in who gets included and, really importantly, inconsistent use of those key procedural steps we discussed, like always doing POT or consistently avoiding KBI with DCBs. If the techniques aren't standardized across trials, it makes it really hard to compare results and draw firm conclusions.
And some of the older trials might actually muddy the waters if we're not careful. They absolutely can. It's crucial to distinguish between studies comparing DCBs to modern drug-eluting stents versus older comparisons. Some early trials, like DBOT and Babylon, tested DCBs but used them in combination with older bare metal stents, BMS, in the main vessel. We know BMS just don't perform as well as modern DES. So when those DCB plus BMS strategies looked worse than Dispoba strategies, it wasn't necessarily a fair reflection on the DCB itself. The authors strongly emphasize that our current decisions need to be based on data comparing DCBs against the current standard of care, which is DES.
Okay, let's push into the more advanced aspects now. We know that for complex bifurcations, just looking at the angiogram isn't enough. The review strongly advocates using intracoronary imaging, ICI, like IVUS and OCT. Why hasn't imaging been as central for DCBs as it has been for stents historically?
That's a great point. Historically, ICI was heavily focused on optimizing stent deployment, making sure the stent was sized right, fully expanded, pressed against the wall. That was the main therapy. Its role in DCB procedures was sort of underappreciated initially, but that's changing fast, precisely because, as we discussed, DCB success hinges so much on perfect lesion preparation. OCT, with its incredibly high resolution, is fantastic for seeing subtle details, small dissections at the edges, making sure plaque is adequately fractured, or spotting any remaining thrombus or clot, all things that impact DCD outcomes.
And IVUS, the ultrasound-based one.
IVUS intravascular ultrasound gives you better depth penetration. It's really good for accurately measuring the true vessel size hidden behind the plaque. It also helps quantify the overall plaque burden and see how it's distributed. This is vital for choosing the right size DCB to ensure good wall contact for drug delivery.
Is there direct evidence that using IVUS actually makes DCB procedures better?
Yes, there is. The Ultimate 3 trial specifically looked at this. It showed that guiding DCB procedures with IVUS resulted in significantly better acute gain, meaning a wider vessel immediately after the procedure, and also reduced the amount of re-narrowing, the late lumen loss at 7 months. The comparison was MATIS 0.1 millimeter LLL with IVUS versus 0.03 millimeters with angiography alone. So imaging guidance leads to objectively better results.
Now, here's something that really caught my eye in the review, a surprising take on dissections. We usually think of tears in the artery wall as bad news, but they suggest certain types of dissection might actually be good after a DCB.
Yes, this is a fascinating and potentially practice-changing insight. It's a bit counterintuitive. Emerging evidence suggests that small, controlled dissections that only go into the middle layer of the vessel wall, the media, might actually be associated with better long-term results after DCB-only treatment. The thinking is that these controlled fractures could create channels allowing the drug to penetrate deeper into the vessel wall, maybe enhancing the anti-growth effect compared to just superficial delivery. Of course, this highlights again why imaging is crucial. You need to distinguish a potentially beneficial, limited dissection from a dangerous, flow-limiting one that needs stenting.
Beyond seeing the anatomy with imaging, the review also stresses using physiological tools, FFR or IFR, to measure blood flow. How do these fit in, especially for assessing that side branch after the main vessel stent goes in and it looks a bit pinched or jailed?
They are absolutely crucial, mostly for promoting a conservative, evidence-based approach. Like we said, after you stent the main vessel, the opening to the side branch often looks narrowed on the angiogram. It looks angiographically significant. But pioneering work by Koo and others showed that when you actually measure the pressure drop across that narrowing using FFR or IFR, many of those jailed side branches are not hemodynamically significant. They aren't actually limiting blood flow enough to cause problems. So physiology confirms that we can often safely leave those side branches alone, deferring unnecessary stenting. This fits perfectly with the whole leave less metal behind DCB philosophy.
That's for assessing the result. Is there any role for physiology during the procedure, maybe to guide the preparation itself?
That's an interesting developing area. There's some retrospective data, meaning looking back at past cases, that suggest a specific pressure ratio might be useful. They found that achieving a PDPI ratio that's distal pressure divided by aortic pressure of 0.90 or higher after lesion preparation, but before applying the DCB, might indicate you've done an optimal job preparing the vessel. If this gets validated in future prospective studies, it could give operators a functional target to aim for during the prep phase, ensuring the vessel is truly ready for the drug.
Lastly, let's touch on the patients who might benefit most from this whole stent-sparing approach. High bleeding risk patients seem like obvious candidates.
They really are arguably the group that stands to gain the most clinically. DCB strategies, by minimizing or even eliminating permanent metal, directly address their biggest problem: the need for prolonged diopy. Allowing for shorter diopy regimens significantly reduces their bleeding risk. We have trial evidence, like from REC-CAGE-free 2, supporting the safety of very short antiplatelet therapy after DCB treatment in HPR patients. Moving from potentially years of diopy down to just a few months is truly transformative for these individuals.
What about other complex groups, patients having acute coronary syndromes, heart attacks, or those with diabetes? They tend to have worse outcomes generally.
For acute coronary syndromes, or ACS, the idea of using less metal is certainly appealing, especially if there's a lot of clot involved. However, we don't yet have large-scale randomized trial data, specifically looking at DCBs in the setting of bifurcated ACS lesions. The potential benefit is there, but needs more study. It's a similar story for patients with diabetes. They often have more aggressive, diffuse disease and higher rates of restenosis. DCBs have shown good results, especially in smaller vessels, which are common in diabetics. So the rationale for using them, perhaps in a hybrid strategy, is strong. But again, we really need dedicated large trials focused on these specific high-risk populations to fully confirm the benefits and make it standard practice.
Well, this has been a fascinating deep dive. It really feels like DCBs are shifting from being just a niche tool to becoming a core part of the strategy for provisional stenting and bifurcations.
I think that's exactly the right takeaway. We now have solid level 1 evidence showing DCBs are better than just plain balloon angioplasty for the side branch. They offer real clinical advantages, particularly in reducing MEE, driven mainly by fewer heart attacks, all while preserving the natural vessel anatomy. When you combine them with essential techniques like POT and guide the procedure with advanced imaging like IVUS or OCT, you get a really optimized, effective, and safe approach for managing these complex lesions.
You've really painted a clear picture of how the drug, the mechanics of the procedure, and the imaging all need to work together. And this whole conversation really drives home the point that we need to look beyond just how the artery looks on an angiogram at the end, which leads to a great final thought for our listeners to chew on.
Exactly. If we accept that DCBs are superior to POB, and we see how critical imaging is for guiding preparation and maybe even understanding things like beneficial dissections, then the next big question is, what specific metrics should we be using? Beyond just saying less than 30% stenosis, what advanced imaging criteria or maybe even functional measures should be standardized in guidelines worldwide? Especially for the most complex cases like the left main. How do we ensure that everyone using DCBs is achieving truly optimal, reproducible long-term results? That standardization feels like the next major hurdle.
A really important challenge for the cardiology community to tackle.
Indeed it is.
Thank you for watching The Funnel Effect.